as John is being tested, this is also now part of an NDT prac for you on this course. So I'll ask everyone to maybe put their notes down, come around a lot closer, have a look, and I'll talk you through what I'm doing as I'm testing with John. I'll just go through and explain it. John is short of R1. What do I mean by that?
React.
Yep, so really I'm just saying he's at rest. Correct? No sort of guarding at present. So you know if someone's reactive at present, you have to move their position until you can get them no R1, or at least as little as possible. And because John's been moving and showing me exercises, I'm pretty confident I can just lift his arm up and get going. But if someone's really quite severe and acute, you might have to start testing someone just like this first. So don't just jump in and lift everyone's arm straight up. But you're giving me an example of someone who looks like I can get up like this and like this straight away. Next thing I'm doing is I'm not winding up somatically. So I'm going to sense with my fingertips in a position I get to, oh, right there, I start to get some tightness around the shoulder, 85 degrees or 80 degrees. So I back off a couple of degrees. Now we're definitely short of any somatic R1 and guarding. And I work out when I do external rotation, oh, right there it starts to tighten up. Don't go further. Come back. Yep, so we're avoiding any false positives from somatic guarding. I'm applying what I think is comfortable pressure through your forearm into my hip. And I need you to speak up if it's, really speak up, John, please don't be nice to me. If I'm creating wrist tension or something else, I've got my fingertips all the way to the thumb, all the way to the fingertips to make sure we got neural right on and not accidentally missing some of it, because that can make a big difference, and you'll feel as a client it's not very confidence building if you miss these key thumb and finger extension. So enough compression through the forearm so you can feel relaxed and confident with my handling, John, but not so much compression that I really yank the wrist back too much. So it's tricky. You need feedback, and you guys will have to give each other feedback to make sure you're getting this in prac. I'm using my hands and fingers around upper trap area, levator scap area, supraspinatus, scalenes. See if there's any protective guarding. So the compression down through the elbow needs to remain axial if I'm to help John relax. And see how I do the wiggle to sort of ensure that he's relaxed? And if John does any sort of active guarding, then I've just got to try and catch if that's because I'm not giving him confidence, or as if it's because there really is some somatic positive kicking in. And that's it. See how it's a different point, the guarding's coming on each time. So I think it's my handling that I should be able to do to help John feel more relaxed. Now, John, you need to speak up, please, at any point you feel pulling. Am I already giving you too much pulling? Like pulling here? Should I back that off? You tell me.
That's it.
No pulling. Good. Okay, if I come down here, I can feel your muscles guarding. Can you just let me know, though? It just changes each time. That's right. You can help me go out straight, actually, to begin with. It's okay. Active and passive is equal. Oh, just start to get it. I just felt it when you started to. Hold on a second. I've got the reaction here. So let me get to just that point. Oh, right there. Got it?
Yeah.
Now we've got to measure. I'll take you off. Too easy. Yeah, so we've got a positive. Because this is just the first test, I won't take a photo just yet. There might be one that's more positive than that. But we'll write down right upper limb. Minus 25 actually, minus 25 degrees, positive upper limb. Does everyone see that? Mm-hmm. Good. If that is the most significant one, that's the one we're going to fix. We'll take a photo of it just before we fix it up. Now, who's going to repeat for me, please? What did I just say as I went through for good manual handling to give John confidence in my manual skills, as well as make sure we're getting accurate tests, not accidental false positives? Someone put their hand up and speak up and take me through the handling that I'm doing.
Pushing through the axes.
Good. Tell me another.
Making sure you're starting.
There's a little pain here.
Thank you.
Because I think I'm getting arthritis.
Thanks. So what I'll do is I'll change my handling like this, John. Mm-hmm. See if I can do it maybe like this. You tell me what it's going to take to get the pain away from there.
There's a little pain there.
Okay, I'll have to do something different. Tell me again.
Better.
Not quite 100% yet. Tell me again.
Not okay.
And if that changes as I go through range, you need to tell me if it increases. No, very different to the other side. If you can sense that the same as I can, negative. I'm going to start with the setup position for upper limb neural dynamic testing. We've got Reese in a position where he's just lying standard supine position, and I'm going to check with my palpation all through cervical extensors, upper traps, and right at this moment Reese is not as relaxed as he possibly could be. What can I pick that would make Reese maybe potentially not so relaxed? You might be able to spot it from there, really. The pillow height. So even if I pull the pillow back out of the way, going back down, that's better already. And if you're able to see from where you are, he's already actually more floppy and relaxed in that position. So that was my demo of, getting a nice sort of setup there for relaxed, no R1 for Reese. The main one that can capture all three sort of main upper limb nerves is going to be the median nerve bias. So it's not so much about what nerve is the problem, we're just after a positive or a negative. And if you can see my demo at the moment, I'm treating Reese like someone who would be typical for our clientele, and that is, you're not pale, you're not sweating, you're not about to vomit with a nerve root irritation diagnosis. You're in pretty good shape, but you just have a condition that needs solving. So that means I can just pick up your arm and start to go straight into position. I wouldn't do that if you were white and clammy and pale and sweaty, because we could do the test in a very, you'd be tested in a much less provocative position, wouldn't you? So let's just go through testing this in what's fairly standard. And what's fairly standard is I'm going to take your arm up to, and I'm keeping floppy the whole time, so we're staying short of R1. And I'm going to take your arm up to an abducted position. And you might remember me saying before, we're going to watch for R1. The R1 I'm watching here is specifically, it's probably going to be a somatic R1. You're going to have some potential, joint tightness or muscle tightness or something around your shoulder, around your thoracic spine, anywhere in your arm. And that will, a point where your shoulder starts to elevate is the point where I've got to stop abduction. How did everyone go with that? So I've got abduction at about 70 degrees here for Reese, and we don't abduct any further, because to go any further is actually creating guarding around here. Now, if we create guarding, we're not going to get a sensitive neural dynamic test. We want to make sure we're short of all guarding. Again, make sure how much extension you go into. So we're still in the shoulder. How much extension can you go into? Well, that's enough. So I'm about 20 degrees off horizontal, if everyone can sort of imagine that from the angle that you've got on the video there. And once we get there, I'm still checking everything's nice and loose and floppy with this hand. And we'll take supination. I will take my fingers out onto the fingertips. Definitely go all the way to the fingertips. If you can see my hands there are over onto the fingertips here of Reese to make sure we get full finger extension. My thumb is sort of locked in about the back of Reese's hand so that I can create a comfortable enough force for wrist extension that I can sustain the position. I compress down through the forearm into my hip or thigh. That compression is purely for confidence for the client that I have the weight of his arm very securely taken up. I'm not increasing any R1. If at any time a client experiences any symptoms during this, they must speak up. So Reese, I'm going to tell you, if you feel any pulling, tension, pins and needles, pain, anything, the onset of that, you need to speak up. I will do my best to sense the test and stop it before we get to that point. But if we do get to that point, I may have missed it, so you've got to speak up and don't let me go any further. So we don't do provocation with this testing. So what I'm doing here is just double checking. Reese, as I compress your forearm into my thigh and I push your wrist in a sensitized position, so I have Reese in a very solid position where he is floppy as can be, and I have a good solid control over his limb. I now, while he's sensitized, I'll go and palpate Reese's upper traps, and even if I can show you on this side, my hand's going to be sort of spread widely, my fingertips, some deep, some superficial, all around the whole neck extensor upper trap area, and I'm sensing for where muscle contraction occurs, if any. And at the moment there's none, and then I extend the elbow until I get a sense of contraction in Reese's upper trap area, and I go all the way out, and absolutely nothing. So very relaxed and floppy proximal muscles. What I'll do now is go on with a hypothetical of what if Reese did react. If you're ready for that. So let's do a hypothetical now, and this is what a client will typically be like. I will keep my fingers here, I will get to this point and go bang. See my hand jump, bang. There was tension under the upper traps here. It can be very subtle in some people, and sometimes it's not subtle at all, it's very obvious and dramatic. If that were the case, I would measure something like -70 elbow extension right now at the onset of R1. I would then desensitize so that the neural structures are now not on tension. I extend the arm now and I get a different range without the wrist with the wrist desensitized. That's my measure in that hypothetical there that you would be positive ND testing. Positive NDT. What made that a positive measure? The fact that there was a difference in range when you were sensitized to when you were not sensitized. Completely independent of symptoms. The whole time we did it without any symptoms or without any increase in symptoms. It was an objective test. I'm able to tell Reese what the result of the test is without any reports from him. You don't have